Hello and good evening to all of you. So, I hope all of you are doing fine and a very warm welcome in this session. So, it's going to be a short session, not a lengthy one, and we would try to make it as interactive as possible. Now, this labor care guide, it's a very hot topic. It's like hot topic from examination point of view and also like, of course, in our daily clinical practice, isn't it? All right, so now, uh, I will need four volunteers. See, because I know many people wanted to present this case, but if I will give chance to just one of you, then I think it's not fair. So, what we can do that there are seven sections, isn't it? So I will need at least four or five volunteers, and I will divide the sections. So everyone can get 3 minutes to perform. Okay. So I hope that that would be fine so that like it's going to be a bit interactive and then we will discuss how to fill each section one by one. Okay. So, and all right. So I need volunteers. Let me show you the scenario so that you people will be prepared. Don't take it as a uh, practice session and I have to finish everything in time. No, it's like a discussion session, and we should learn in this session how to fill the labor care guide correctly. Okay, so this will be the first slide. Second slide, of course, I'm going to enlarge it. I will need the first volunteer to fill the first two columns, then one more volunteer to fill the next two columns. Of course, you will be getting the enlarged pictures so that it will be easy for you to comment. All right. Now, take it easy, my dears. Take it easy. We are all here for a discussion session. The practice sessions also I'll arrange later on. But as of now, it's going to be discussion session. But of course, you people have to present. So who will come forward? Who wants to present first? So you also have to explain what is labor care guide, its aim and importance. Okay, and then the first volunteer will fill at least two section. All right, so come on, please. Who would like to
Yes,
come?
ma'am. Mm-hmm.
Whose voice?
Kazi. This is Kazi, ma'am. I can remove.
Kazi, my dear. Okay, after
Yeah.
Kazi, who will, after Dr. Kazi, who would like to volunteer? We have so many. So, someone should come forward, huh? Uh, after you're Dr. Mahmouda Qazi, isn't it?
Yes, yes, yeah.
Okay, so I have one volunteer. Second, who would like to come forward? Take it easy, my dears. Please, take it easy. We are just like colleagues. If no one would come forward, then Dr. Mahmouda Qazi can continue. But it will be more interactive if someone can come, because see, I'm going to show you the sections also. These are the sections. You just have to comment how to fill, okay? Right?
Yes, yes.
Exactly. Exactly. Okay, so Dr. Mahmouda, you can start. Um, the slide is clear. Can you see? Hello? Hello, Dr. Mahmouda, can you hear me? Mahmouda Qazi? I cannot see her. Okay, Dr. Mahmouda, is there any problem in your connection? Okay,
Am
so
I audible? Sorry, yeah, am I audible?
now your voice is coming. Yes, I thought, where did you go?
No, no, no. Sorry, no, yeah.
Okay, sweetheart, see, take your time, okay?
Mm-hmm.
You will start as the teaching session you with your introduction. Okay,
Okay.
and you will take the first question, explain the labor care guide, its aim and importance, and then
Mm-hmm.
you can fill the first three sections, no problem. After that, I will see who will take, who will come forward.
Okay. Mm-hmm.
Start,
Okay, nice.
start,
Will
please.
I take 2 minutes or start immediately? I think we can start, right? Because nothing else.
Take your time. Take 1 minute. It's okay. Read,
Okay.
read the scenario properly. Organize
Mhm.
your thoughts.
Okay. Okay. Yes, ma'am.
Start, please. Okay.
Hello, I'm Kazi, the ST5, and you?
Hi, I'm Nita Joseph.
Okay. Sunita, how are you?
Yeah, I'm good. Thank you.
Okay. And how is going everything in the department?
Yeah, everything is good.
Mm-hmm. Do you feel supported?
Yes.
So,
Yes.
okay, that's fine. Okay, so anytime you feel any problem, just let us know. We are here to help you. Okay.
Yes.
Okay. So, Nita, I understand that today you want to discuss about the labor care guide. Am I right?
Oh, yes. I have this labor care guide and I really want to know how to fill each and every section.
That is really a very important topic. Like we were covering the labor word, and it is very important to know how to feel and how to interpret. So, may I know specifically why you want to learn this today?
Yes, because I'm covering the labor room and
Mm-hmm.
I saw my senior and the midwife filling this labor care guide and they did it so fast and then they asked me to fill one more labor care guide for another patient. But I was not able to fill, I mean, I don't know how to fill the sections.
Okay, okay, no worries, no worries. We are here to help. So it's it's usual. Like if we are first time we are doing this, so like if I'm were in the same situation, so it is the like similar situation I would also face, right? So no worries, we are here to help you. Just one question, like any idea about this?
Well, I read it, but
Mhm.
I don't have much idea about it.
Okay, okay. So do you have any specific concern, like any particular point you want to learn?
Well, I want to know how to fill each and every section and what's the importance of this labor care guide.
Okay, okay, that's fine. So I will discuss everything, and in between, if you have any question, don't hesitate to ask. And I will give you some articles after that. Like we have the WHO Labor Care Guide. There is a document I will provide you, and there is another nice talk article to read the difference between the partograph and this new labor care guide. Okay, and you can give me the
Yes.
feedback. And if it is a like big topic, so if you cannot like discuss everything, we can have
Yes.
another session as well. Is that okay for you?
Yes, yes, that's
Okay.
fine. Okay.
Okay. So you have you already know about the partograph, right?
Yes.
Okay. So I'll be going directly to the labor care guide. So
Yes.
labor care guide, it is like modified. Some in the, some sort of apart from this partograph, some new topics are added here. So this is done by the World Health Organization. It
Mhm.
has 7 sections. Ma'am, can you go to the next page to show this that page?
Right.
The labor care guide, yeah. So like first page, the previous one, yeah. So as you can see, this is the labor care guide. Here we need to fill this one. So you can see there are 7 sections. So the first
Mhm.
section is including identifying points, for the like maternal identifying points, the demographic points, and also during the admission of the what is the initial position of the labor. So this one we need to fill. In the second section, you can see that this is like not very bigger. Okay, so this is the like some of the condition in terms of supportive care. The third section is denoting the baby's condition, and the next one is the maternal condition.
Yes.
Yeah, the care of the women. The fifth section denotes the progress of the labor
Yes.
progression. The sixth one is the medication related things, and the seventh section is the shared decision making. Okay, so
Yes.
I will be telling you first that what is the like similarities and the dissimilarities in terms of like from the partograph. So as you can see, like some of the topics are still there in the partograph. As you can see, the first section, that is the demographics, patient demographics, the fetal condition, the maternal condition, the medication. These are all the similar things, like progression of the labor. So all these are the similar things. So some are the difference in between these two sections. As you can see that usually in the partograph, we are starting from the 4 centimeter dilatation of the cervix. Am I right?
Yes. Okay.
So this is the like one important point which is dissimilar from there, that we are starting from the 5 centimeter of dilatation. Okay, am I
Yes.
clear?
Yes.
Okay. Now, in the progression of the labor, in the partogram, we are following that 1 centimeter per hour dilatation. That is the fixed timing. But here we are not following this fixed timing, a bit flexible. And in every section, we are feeling when the alert part is there or like not alarming. Okay, we can go ahead. Now you can see that there is a supportive care part. Okay. So the second section, it was not there in the previous. Okay. So
Yes.
here you can see that companion, the pain relief, oral fluid, and the posture. These are the important topics we have added in this new labor care guide.
So how
Okay.
to fill section 1 and section 2?
Okay. So now coming to the section 1, as you can see, then this is the labor care guide, and here the name of the patient. Okay. So here we can see that Mary Jane Williams. This is the name of the patient. The parity is the parity 2. So they have written here the parity 2 will write here. Labor onset. Here we have to write that whether it is the induced or the spontaneous. So here we can see that this patient was spontaneous labor. So that's why they have written the spontaneous one. Am I clear so far?
Yes, very clear.
Okay.
Okay.
And in the third, like here you can see that labor diagnosis. So they have written the date and ruptured membrane. Okay. When the ruptured membrane and the time of the ruptured membrane. Okay. If
Yes.
it is not ruptured membrane, so it will be like intact. Am I clear
Yes.
so far? Yeah.
Yes.
So we have another section also to write the eye, and if the membrane is ruptured, so the color also. So I'll show you in a bit. Okay. Then the risk factors. So the risk factors such as the history of stillbirth, anemia, they have written that in this patient it was the risk, the stillbirth anemia, but we can have like other risk factors like if previous history of cesarean section. So this one will be the VBAC. So that will be another risk factor. So we have to identify the risk factors and write here. Am I clear so far?
Yes.
Okay. So can you mention one of the important point like when we will start this partograph in this labor care guide
Yes. When
in
the
terms of
cervical,
cervical dilatation?
yes, when cervical dilatation is 5 centimeter or more.
Perfect. Yeah, perfect. Excellent. Yeah, you are a fast learner. Yeah. So now coming to the second one, the sections 2, right? So
Yes.
this is the supportive care, as you can see. In
Mm-hmm.
the supportive care, before supportive care, just I would like to show you one thing that you can see the time and the hours. So
Mm-hmm.
when we are starting this time, we will write here. So it is the 6 a.m. So we are writing here the 6, right? Okay.
Yes.
In another section, you can see here is the alert. This was also the new one. Okay. This was
Yes.
not like this one. In the alert section, for all of the sections here, like section 2, 3, 4, in everywhere they're writing what is the alarming point or the alert. Like if the companion, so
Mm.
N means no companion. So here you have to encircle with the red color, meaning that
Yes.
like it is an alert point. So every time is there is any alert point in any of the section, we have to make a red circle. So
Yes.
no opinion is a alert. Yes, you can see that we are writing Y, so there is no encircling, red encircle. Okay.
Right.
Okay. Now coming to the pain relief. So in the pain relief also no pain relief. It is again the alert. So that's why they have given a circle. But it was on the 7, like after 1 hour they have started. So there is Y means yes. So it is not encircled. Am I clear?
Yes, very clear.
Nita, now you can see that oral fluid also. If no oral fluid, it will be another alerting point. But here she is taking the oral fluid, so that's why they have written the Y in the both of the both hours. Okay.
Yes, okay.
Another thing is the posture. So they are writing like if the posture is SP means the supine position, that will be our alert point. So that time we have to give an insert. So here you can see that MO means she is mobilized. That's why they have written in the 6 hours it is MO, but on the seventh it was supine position. So that was written SP and they have inserted.
All right. Okay.
Okay.
So,
Do you
yeah.
have any questions so far?
No, no. Thank you. It's very clear. Okay.
Mm-hmm. Should
So,
I go to the section 3
yeah.
or
So
not?
here, supportive care is a new column. Alert
Yeah.
line. This is a new column.
Yeah,
We're going to
and here
start.
another thing is it is not shown here. Like it
Yes.
stage, there is also the second stage of labor. So, like if you can go to the next page,
Yes.
I can see all the points all together,
Right.
which is the
This
new
is
one.
the
Yeah,
second stage. I
yeah,
will
yeah.
enlarge
Yeah.
it. Okay. So,
Okay, the second stage is also the new here. It was not previously there,
yes.
and this, you can see that the last part is the like what is our implementation part, like what the plan will be given, and the initial part. These two also newly added here.
Right. So you filled section 1, section 2. Okay, Dr. Kazi, I will just stop you here. Thank you
Thank
so
you, ma'am.
much
Thank you so
for
much.
volunteering. Now, who will come forward to fill the section 3 and 4? Please come forward, my dears. We are just discussing how to fill the labor care guide. Take it easy. We have
I
so,
can try, ma'am.
yes, whose voice is this?
Khush- Khushbu.
Khushbu. Yes, very good. Well done. Come, please. Okay, so yes, you can start from here. If you want to introduce yourself, you can do, or as you wish, or if you want to start from here, you can start from here.
Okay, so uh, hello, I'm Khushbu, one of the exam candidate. I have gone through the scenario and ready for discussion. So here I have
Fine.
labor
Start from
care
here.
guide.
Oh,
Okay,
yes, yes,
so here I have labor care guide, having various sections. So coming to the section 3, which demonstrates the care of the baby.
yes,
So basically, the first column is for heart rate, which generally, as per the new NICE guideline, they have taken as the reference as between 110 to 160. So we have
yes,
to just fill up this heart rate, what exactly it is, and if it lies between 110 to 160, we consider it as normal. Coming to the next, any deceleration. So we have certain criteria that from the baseline heart rate, if it is dip at least 15 beats per minute for 15 seconds, so we consider it as a deceleration. So generally, we just mention it that which type of deceleration is present, if yes or no. Moving ahead, we also see the amniotic fluid color. So M for meconium, C for clear liquor, and B for blood stained liquor.
mhm,
So as per that, we just fill it as SE, MB, whatever it is, and then we determine the v- position of head, uh, depending upon which station or where exactly it is. If at all any caput is there, so degree of caput is also mentioned. Severe grade caput for 3 plus and mild caput is single plus. And molding also, severe molding 3 plus or mild molding is just for 1 plus. We
right.
fill it like that.
Okay, so can you tell me what is L and what is this N and V? Deceleration?
So generally, there are three types of decelerations. So late decelerations is, we consider late decelerations as pathological, and we variable decelerations, we just mention it with V, and a normal variant, the decelerations which are just coinciding exactly with the uterine contractions, we label it with N.
Yes, so that, yeah, that is, or no decelerations. E is early deceleration, the one which you're saying coinciding, the mirror image, right? And if this is going to be your alert column. So anything here is an alert. So L is an alert, late deceleration, right? Likewise, 3 plus meconium and blood stain liquor is an alert. C is clear meconium, not an alert. Occipito posterior, occipito transverse position will be an alert. Caput and molding 3 plus is an alert, right? So the question junior asked in the exam was, what is caput and molding? Can you describe briefly?
So, caput is it is generally the presence of fluid accumulated beneath the scalp.
Very good. Yes.
Uh, so,
100 degrees. How many
which
degrees are there?
can, which can cause a temporary swelling of the scalp as well. So, it doesn't defined by the particular suture line.
Mm-hmm.
And molding is overlapping of the various sutures like sagittal sutures or occipital
Yes.
sutures. So gap is there. So overlapping of the sutures is molding.
Yes. Okay. And if it is 3 plus caput and 3 plus molding, that will be an alert. Fine. Okay. Take one more
So
section. Yes.
generally,
And there
so
was one
generally,
more. Yes, go on, Khushbu. Yes, please.
so 3 plus means that there is difficulty in the progress or might be some obstructions for the progress of labor is there. So that is indication for expediting birth either through a cesarean section uh, or whatever depending upon the cervical dilatation. So 3 plus caput is like we have to now take urgent intervention.
Yeah. So whom will you inform if you have to take urgent intervention? There is a
So
domain of
generally
communication with colleague as well.
it's
So,
a shared. So
yes.
generally it's a shared decision, and we have to ask for the help from consultant available
Yes. And senior midwife.
before any intervention.
Exactly. So see, it
Before any intervention.
yes, yes. It looks very simple that we just have to talk about section 1, section 2, section 3. But keep in mind, you also have to talk about the domains. One is communication with colleague, the junior, with whom you're interacting. Other colleagues will be your midwife, your anesthetist, your consultant. So in section 2, if there is no pain relief and she wants pain relief, because we have to assess her every hour. So no pain relief. If she wants epidural, we have to inform anesthetist. You will get a mark in communication with colleague. There is no companion, so we can ask one midwife to be with her or ask her partner to be with her. So provide one-to-one support. Who will provide that? The midwife. So you will get a marks in communication with colleague, isn't it? So here, yes, if there is any deviation from the normal, labor is not progressing well, any fetal distress, fetal heart rate deceleration, like late deceleration, we have to inform the senior midwife and our consultant. So this is how you are talking about communication with colleague. Okay, well done. Okay, so let's move forward. Yes, one more question was, how are you going to fill these sections? Section 2 every 30 minutes, every 1 hour, or every 2 hours? How do you fill section 2? Is it
So so
anyone can say, either Khushbu or anyone can volunteer?
Section 2 will be
Every
hourly.
hourly, ma'am.
Hourly.
Hourly, exactly. It is hourly. These are the boxes. So it is every hourly. Now, baseline fetal heart rate and fetal heart rate deceleration. What do you think is the
30
minimum
minutes.
is
30 minutes.
30 minutes. 30 minutes in the first stage of labor.
Yeah.
Fetal heart rate, it is
first
intermittent
stage.
auscultation, 30 minutes, every 30 minutes in first stage of labor. And what about in second stage of labor?
Every
Every
15 minutes.
15, 5 to 15 minutes.
5 minutes, usually 5 minutes. Yes. What about amniotic fluid, fetal position, caput, and molding? What do you think? How will you
Hourly.
do this?
4 hourly.
Four
So
hourly. Because it will be when we are doing the vaginal examination,
Vaginal examination.
only then we are going to fill it. And if labor is progressing well, then we are going to fill it every 4 hourly. Okay? No confusion until here? Okay. At the end, I will revise all the sections again. Okay, so Khushbu, would you like to do the section 4 as well? And after Khushbu, please, I need one more volunteer. Okay, yes, Khushbu, carry on with
So,
this one.
yes, moving ahead, section 4 generally, we just take the parameters of maternal well-being, mother. So, we measure what is the pulse rate, blood pressure of patient temperature, and whether there is associated proteinuria and the urine output. So, generally, we already know that 120 to 120 by 80
Yeah, so this will be,
120
right,
systolic, diastolic. Yeah,
exactly, right.
above 140 is generally indication that preeclampsia could be associated. Temperature 37.5 till 37.5 we consider normal. Above that, which means that we can suspect any sepsis or any maternal fever is there. And urine output, we generally proteinuria we have to measure. So depending upon the amount of proteinuria, we take 1 plus, single plus, or double plus.
A is, what
If
is
it is
A?
present or absent.
What is A? Anyone?
Acetone, ma'am. Acetone,
Acetone.
acetone.
Yes, so acetone means what? If there is acetone, patient is
Uh,
Dehydration.
exactly.
Dehydration.
Dehydration.
Ketone
Hydration,
bodies.
yes, yes. So we will ask her to take some sips of fluid or start IV fluid if indicated. All right, now how are you going to fill this column? Every 1 hour, 2 hour, 3 hours? How many hours? Care of the woman?
Every 4 hours.
Every 4 hours. Excellent, because this is 0 hour, 1, 2, 3, 4 hours. Right. Now, one volunteer. Thank you, Khushbu. Thank you, Dr. Kazi. One volunteer
Thank you,
for
ma'am.
section 5. Take it easy, my dears. We are just interacting. So many, but no one wants to come forward. Everything is right in front of you, my dears.
I'll try, ma'am.
Whose voice?
Sindhu.
Sindhu, come forward, please. Yeah, very good.
Yes, ma'am. So in the section 5, we have a number of contractions per 10 minutes. So if it is either less than 2 or more than 5, then it comes in the alert line. So if it is more than 2 and less than 5 should be normal. So we have to mark them accordingly, like how many contractions they are getting here.
Mm-hmm. Okay.
And duration of contraction, if it is less than 20, it means that it is less contraction. So we have to find out whether we have to start syntocinon or anything. If it is more than 60, it is hyper stimulation. So we have to inform the consultant or the senior midwife and do accordingly. If it is normal, then we have to enter it here.
And in first stage of labor, what's the interval to measure contractions? I mean, frequency and duration of contractions? Every how many minutes?
Half hourly.
Every 30 minutes.
Half
Yes,
an-
yes.
uh,
Every half an hour. Yeah. And
yes,
in
ma'am.
second stage of labor, every 15 minutes.
15 minutes.
15 minutes.
15 minutes.
Very good. And this column is an alert column. Very good.
Alert. Yeah.
Yeah.
And here next we have cervical dilatation and descent. So cervical dilatation, we do have an evidence-based timings for the dilatation, ma'am. So we do PVA every fourth hourly. For example, active stage starts from 5 centimeter. So we have to calculate from 5 centimeter. So for 5 centimeter, if patient takes more than 6 hours, then it comes under alert line.
Yes. Okay.
So she's 5 centimeter. How many hours she has taken that we are supposed to mention here. So if it is less than 5 hours, then it is normal.
Yes.
I mean,
Okay.
less than 6 hours. So
And
again, after 4 hours, we'll be checking her PV. If
yes.
she's around how many centimeters she is, we have to see. So if she's around 8 centimeter by then if she has taken more than 2.5 hours, then it is alert line. If she has taken if it is less than 2.5 hours, if she's become 8 centimeter, then she's progressing normally.
Yes. Okay. Fine. And
So
this is
when she's fully
located by
dilated,
X. Yeah. Plotted by X. Okay.
plotted by X, and when she's fully dilated, that also should be entered, ma'am. And similarly, just like doing cervical dilatation, we have to see what is the station of the head as well,
Mm-hmm.
and position of the head has to be marked.
So how will you plot this one? Descent?
We have to plot 0.
Yeah, so what examination is it? If it
PV examination,
Abdominal, yeah.
abdominal
the
examination.
abdomen,
How many fifths palpable?
Yes, it is
uh,
actually how many fifths palpable. It is not the
palpable.
stations. Yes,
Yes,
so 5 by 5th, 4 by 5th, 3. So as the labor is progressing, the head will be engaging, isn't it? So
it should be less palpable.
exactly, it has to be less palpable. In the end, it has
Palpable.
to be 0 by 5th. Okay.
It's palpable.
So this is cervical examination is vaginal examination. Descent of the head is by the abdominal examination. Right. So no confusion should be here. It is not the stay. It is the 5th of the head palpable. So it is abdominal examination. Well done. Okay, Sindhu,
Thank
talk
you, ma'am.
about who will talk about medications and the last section. Easy ones. Thank you, Sindhu. Anyone else? Okay. So Dr. Kazi, if you are still there, come please.
Yes.
Go on, please. Your friends don't want to volunteer. They want to give you the chance. Okay.
Thank you, everyone.
Okay. Okay. Go on, please.
Okay. So regarding the medication, as we can see here that it is written that oxytocin and any other medication and the IV fluids. In terms of oxytocin, if we are giving it either for the induction or augmentation, so it will be like augmentation as we are starting from the 5 centimeter. So we have to write international unit and the drops per minute. So how many unit and drops per minute we are giving, we have to put it here.
Yes.
It is meaning here in means it is not given here.
Yes.
If
And
we are giving, we have to specifically write here
exactly.
unit and the drops per minute.
Mhm.
And the medication. So if we are giving any other extra medication, we have to write like if a pethidine or any other medication we are giving extra, that one also we have to mention here in terms of the dose and the route, like whether we are giving oral, IV. So specific route and the dose of the medication we have to write here specifically.
Yes.
The IV fluid here also it is N means not given. So if we are giving the name of the fluid and the drops per minute, we have to mention here specifically.
Right. Okay.
Now coming to section 7, the shared decision making. So this is also the new here added newly in the labor care guide. Here we can see that the section is subdivided into assessment, then plan, and the initials. So the assessment is, so we have to assess like whatever we have seen, all the portions of the maternal, fetal, and the labor progression. So considering everything, we have to assess that what is going on. So we have to have a diagnosis here. Like if we have any concern here, we can see it is written for this patient, it was pain relief was required. So here we have to involve, like here it is written that offer companionship, because we know that if one-to-one care, it is also considered as a condition of pain relief. So it will help also in the pain relief. And if at all it is needed, another pain relief in terms of epidural, so we have to involve the anesthetist to provide that pain relief. Additional pain relief is needed. And any other plan, like in terms of progression of labor or in a fetal condition, anything. So we have to involve the other group of experts, that is including our consultant obstetrician and the senior midwife. We have to involve and go further. Like if we have to do any, like in our unit, if it is if there is any problem in the CTG, so we have to go for the FBS after taking the consultant opinion, if the FBS is available, and then further management plan, like should we go for the labor to monitor or go for the further intervention.
Right.
Now here we can see that other continuation of the routine monitoring apart from this pain relief. And further also here we can see the normal progression. So every time they have written that routine continuation of the routine monitoring and pain relief again required. So offer again companionship and manual pain relief, and what is encourage mobilization and continue the monitoring. So epidural was not mentioned, but if we are giving that, then also we have to document here that when we are starting that and who is involved in the care. In the last part is the initial. So we have to write, like give the signature. Like if I am seeing, so I have to give the signature, or you are seeing, so you have to
Yes.
give the specific signature here.
Right. Fine.
Mhm.
Okay. Now,
Any other questions so far?
okay. Yes. What about this second stage of labor?
Mm-hmm.
Okay. So this is
Yeah.
the new one, right?
Yeah, you know, this is the new one.
Mm-hmm. Here, actually, we are not going to plot X because X is for the cervical dilatation. On in stage
Dilatation,
one
yeah.
means cervix is fully dilated. So
Dilated,
no
right.
need of X here. We are only going to mention P, which indicates that patient is pushing, right? Now,
Mm-hmm.
what is the duration of second stage of labor in the primi and multi with epidural? Can anyone say, or Dr. Mahmooda? Can you say?
Yeah,
3 and 2
so yeah,
hours.
in the new one, in the new
Yeah.
guideline, primi gravida usually now like active and the passive. So we have to like 1 hour without epidural for the passive, but active pushing, so it will be 2 hours. So in with the epidural, it can be passive one up to 2 hours. So it total 4 hours can be for the primi. That is the nulliparous.
I think
Three
3 hours. 3
hours.
hours for
3 hours with
primary
For
and 2 hours
epidural,
primary
for
with
Into
multi.
new
for
new
primary with
guideline.
epidural it is 3 hours, ma'am. For primary with epidural it is 3 hours. Without epidural it is 2 hours. For multi with epidural it is 2 hours. Without epidural it is 1 hour.
Right.
Yes.
Yes. Easy. Just remember 1, 2, 3. We are just
Three,
playing
two,
with
two,
these
one.
numbers, isn't it? Or 3, 2, 1. Yes. So with epidural, primi 3 hours, multi 2 hours, and without epidural, primi 2 hours and multi 1 hour. Right?
1 hour.
Yeah. Because with epidural, there is 1 hour of passive pushing. So it will be 1 plus 2 in primi, 3 hours, and 1 plus 1 in the multi. So it's going to be 2 hours. Now, who will explain the difference between the previous partogram and the new labor care guide? The last question we have to
Ma'am,
answer
I had one doubt.
systematic way. Yes?
Ma'am, so do we now, according to the new guidelines, there's nothing particularly passive or active. It's all combined. So do we
Yes.
specify with epidural that there is 1 hour passive and 2 hour
No,
pushing?
no need, no need.
No.
Just this is just for us to remember the hours.
Understanding.
Yes,
Okay.
yes. You're very right. Okay, now who will explain the differences between previous partogram and new
Can I
labor?
try, ma'am?
Ma'am, I have a question
Can I
here
try,
in
ma'am?
terms of, sorry for interruption. I have a question regarding these hours. Isn't it in the NICE guideline they have written that in the primi, it can be until 2 hours for the passive one?
It like
It
till
has changed now.
again,
It was earlier.
Nali
Now they
paras
have changed.
women in the new NICE guideline.
Mhm.
So isn't it written that for the passive, for the primi, it can be up to 2 hours? So if we consider that, so it will be like 4 hours saved altogether?
I think they have removed it now. We have to confirm.
Okay, ma'am.
Anyone has
In,
any answer?
I
in
think I have checked
Yeah,
with
it
ma'am,
is 3 hours
that
GTG,
only.
what it has written.
the new GTG of assisted vaginal birth. So because GTG is more standard as per NICE guidelines, so they have changed. So that is they have removed this active and passive in new GTG. So as compared to NICE, GTG is more reliable source, what we generally refer. That's why they have removed it.
This is what I remember that for
Mm.
primi with epidural 3 and multi with
Mm.
epidural 2 hours. Right.
Yes, ma'am.
Okay. Who wanted to answer this question?
Ma'am, can I try? Can I try, ma'am?
I'll try, ma'am.
First voice. So now I'm getting
Good.
so many volunteers, huh? Yeah,
I'll
who?
try, ma'am.
Well, who is speaking? Your name, please, my dear?
Sindhu, ma'am.
Ma'am,
Sindhu.
Khushbu.
Okay, let Sindhu explain this one. It's okay.
Okay. So, in the previous one and the WHO Labor Care Guide, initially it was actually active phase was 4 centimeter of cervical dilatation, but now it is considered as 5 centimeter of cervical dilatation. And initially there was 1 centimeter fixed per hour, ma'am, dilatation, and there was alert line and action line. Now there is an evidence-based time limits. There is no second stage section, the new column there, but now there is a new column of second stage section, and we do monitor that as well. And there was no supportive care which was given, and now there is supportive care which includes a partner, which includes a pain relief options, fluid intake, everything, including the posture, mobility.
Yes.
And with respect to uterine contraction, we used to measure everything like strength, duration, frequency, everything. So now we just find out like what is the frequency of the contraction she's getting and how many contractions she's getting. That's all. Strength we don't measure. And in any component, whenever there is any alert line, that is deviation from the this one, then we will take measures then and there immediately. But previously it was for only cervical dilatation and descent, we used to take, when there was deviation only in these two aspects, we used to take action, ma'am.
Right. So new columns are now we have this section number 2, supportive care, new, right? Alert column is new. Section 7,
Shared
the
decision
shared
making.
decision
Yeah.
making is new. Second stage is new. Yes, and we are starting from 5 centimeters of cervical dilatation. Okay, and contractions, we are only measuring the duration and frequency of contractions. Okay, now there was one question left. Explain what is labor care guide and its aim and importance. Just 3-4 lines. Can anyone say?
Actually, can I try?
Khushbu or Sindhu? Whose voice?
So,
Kazi, I'm also trying.
Kazi? Yes, okay.
can I try, ma'am?
Yes, try.
Yeah, if you volunteer,
Start,
yeah, try.
please.
So,
Start.
okay. So, basically, labor care guide is it's just the representation of every event of labor on a single sheet of paper, and the basic difference from the previous one is the new labor care guide, it generally measures all the parameter, which includes maternal well-being, fetal well-being. It also take account of progress of the labor and the shared decision making on a single sheet of paper, just to make it easier that whosoever is taking the new handover, they can have every idea just by looking at that single sheet of paper.
Right. Few important things are there. It avoids unnecessary interventions also, because we are starting at 5 centimeters dilatation. Very important medical legal document. It will help in audit as well, right? And it helps the healthcare professional to like start any timely interventions if needed, right? So, okay, all of you have tried it well. Now, okay, so now we will see the answer. We will discuss the answer. Now, whenever you will get a task in teaching station, you have to see the domains which you are tested in. Communication with colleagues, of course, your junior, Nita Joseph. Other communication with colleagues. When you just think in labor care guide, whom I can involve if I'm talking about patient is not having pain relief, I can involve my anesthetist. If she is not having any partner, I can involve my midwife. She can provide her with one-to-one support. And if there is any fetal distress, there is Caput 3 plus, molding 3 plus, decelerations, late deceleration, and we have to expedite the labor. I will inform my senior midwife and my consultant. So this is how you will get the marks in communication with colleagues. If you will just talk with Nita Joseph, you will just get borderline. Of course, you will be tested in communication throughout the station. Till 10 minutes, you will be tested how you are communicating with your colleague. Applied clinical knowledge will be explaining what is labor care guide, its aim and importance. You have to remember a few points. And patient safety is, of course, confirming the first section is very, very important, patient safety here. Patient's demographics, her ID, and the labor characteristics. And like we are starting the labor care guide rightly when the cervix is 5 centimeters dilated. All right, so we will just discuss the answer, my dear. Thank you so much for all the participation. Because, if so many of you wanted to present it, but it's just one scenario. Next time I will try to bring in 2 more scenarios. All right, so introduction and rapport building has to be with smile, go and greet your junior. Hello, I am Shabana, and you are? Hi, Nita, nice to meet you. How are you doing today? How is everything in the department? How about your colleagues? And are they supportive, or do you feel well supported here? Okay, I understand, Nita, you wanted to know about the labor care guide. May I know why? Okay, she will say why. Okay, have you read about it? Do you have any idea about it? Is there any other concern and expectations from today's meeting? So may I know what you want to know exactly about it? All right, so then comes your agenda. So what we will do today, we will discuss about the labor care guide, its importance and how we fill it. And also I will be giving you the important articles and guidelines on labor care guide. And I would also love to have feedback from you about my session. You can touch this point of feedback in the beginning, and in the end, you can elaborate it more. Like we ask, how was the session? How did it go? How can you improve it? All right, now coming to what is labor care guide. So just remember a few lines that it is a graphical representation of progress of labor in which important informations about both fetal and maternal well-being and progress of labor are plotted into a chart against time. So by looking at the labor care guide, we can see we will get information about fetal and maternal well-being and also about the progress of labor, that is cervical dilatation and descent of presenting part. Now, what about the aim and importance? So it helps in monitoring and documentation of maternal and fetal well-being as well as progress of labor. And it guides healthcare personnel to offer supportive care throughout labor. And it helps us to promptly identify and address any labor complication, prevents unnecessary intervention. It supports audit and quality improvement of labor management, and it's a very important medico-legal document. Now, how to use the labor care guide? So we are using it for all women in labor, both low risk and high risk. And of course, high risk women, they may need additional monitoring and care. When are we starting it? Like you all said, that we are starting it in active phase of first stage of labor at cervical dilatation of 5 centimeter or more, and it is used at all levels of care in health facilities, primary, secondary, tertiary, at all levels. Now we know we have 7 sections. So of course you will be asking your juniors, so am I clear so far? Any questions? So can you tell me 1 or 2 importance of the labor care guide? Very good, you're a fast learner. All right, now coming to how to fill each and every section. So I will just go back. So we have this first section. Here we have to fill the patient's demographic, patient's identification, and labor characteristics. So we have to fill 2 things here. So write the full name of the patient, and like we have to check it and confirm it from the medical record that it is the correct name. What is the parity? Labor onset, whether it is a spontaneous or induced labor. Induced, then what was the method of induction? Prostaglandin, oxytocin, or ARM. Active labor diagnosis date has to be filled here. Active labor means when the cervical dilatation is 5 centimeter or more. Then we have to mention whether membranes were ruptured or not, okay, and the date and time. And the risk factors, so this we will know from the history. So it can be like here, history of stillbirth, anemia, or any medical comorbidity like hypertension, diabetes. Patient is going for a trial of VBAC, that is vaginal birth after cesarean, multiple pregnancy. These are all risk factors. Okay, any questions? Fine. Coming to section 2, this is the supportive care. So this is the new column in the labor care guide. Now how to fill this. Here we will see companion, pain relief, oral fluid, and posture. So here again, there is a new column, that is the alert column. So this vertical column here, this is the alert column. So if there is no companion, we are going to fill it with N and circle it. It means that there is no companion, it is an alert. If she has a companion, we will fill Y. Okay, if no companion, then yes, we can inform our midwife to arrange for a companion. And midwife can also be with the patient because ideally we have to provide one-to-one support to our patient. If there is any pain relief or no, so if no pain relief, we will mention N and circle it with red. It is an alert. And we will be asking our, like, if patient is ready, then we can ask our anesthetist to provide with the pain relief. And if pain relief is given, then we have to mention yes, that is why. Oral fluid, if no oral fluid, again, we have to mention N. If she is taking sips of water, okay, that's fine. We will mention why, and it is not an alert. Posture is very important. If patient is supine, then it is an alert because it can cause postural hypotension. And we will encourage the patient to be mobile. Now here, how are you going to fill it? Here you can see this horizontal time axis. So we have to fill it every hour. So if the patient, we have started the labor care guide at 6 a.m., then we are going to fill it at like every hour it has to be filled. So supportive care, we have to fill every hour. All right, now coming to section 3, this is care of the baby. So this is the baseline fetal heart rate we have mentioned here. So normally it has to be between 110 to 160. Less than 110 is bradycardia, 160 or more is tachycardia, it is an alert. How do we fill it? Every 30 minutes in the first stage of labor and every 5 minutes in second stage of labor. Fetal heart rate deceleration. So we know there are 3 types of deceleration: early, variable, and late. So if it is late deceleration, this will be an alert. And if there is no deceleration, it is N. V is variable deceleration. Amniotic fluid, we will see like if membrane has been ruptured, then if it is 3 plus meconium stained or blood stained, it's going to be an alert. If it is a clear liquor, so we will mention C, it is not an alert. Fetal position, occipito-posterior, occipito-transfer is an alert. So we will mention P if it is occipito-posterior and circle with it red. Caput and molding, again it is 3 plus molding, 3 plus caput, this will be an alert. So, and if there is no caput, no molding, it is not an alert. So here, if we have like any deviation from the normal, we are mentioning it in the, like we have to compare it with the alert column. And if we have any concern about the labor progress, fetal deceleration, late deceleration, we are going to inform our senior midwife and our consultant. Now, care of the, okay, here, as we discussed, this column, we will be filling every 4 hourly. Amniotic fluid, fetal position, caput molding, because we will be assessing it by vaginal examination. So this column has to be filled every 4 hourly. Section 4 is care of the woman. So yes, we will be seeing the observations. Pulse, we know between 60 to 120 is normal. Less than 60, 120 or more, alert. Likewise, systolic blood pressure, less than 80, 140 or more, it is indicative of hypertension, alert. Diastolic, 90 or more, alert. Temperature, hypothermia, hyperthermia, these are alert. Urine, protein 2 plus, acetone 2 plus, this is an alert. So acetone 2 plus means that patient is dehydrated. So we will be offering her the IV fluid. This section has to be filled every 4 hours. So this is the 0 hour, 1, 2, 3, and 4 hour. Now coming to section 5, labor progress. So here we see the uterine contraction. So we see the frequency of the contractions and duration of contraction. So between 2 to less than 5 is normal. And duration of contractions between 20 to 60 is normal. Less than 20 seconds, more than 60 seconds will be an alert. And in the first stage of labor, we are filling it every how many minutes? 30 minutes.
30 minutes.
Yeah, every 30 minutes. Is already they have given this jotted line. So this is 30 minutes and 30 minutes, right? Labor progress by vaginal examination. So we have to see the cervical dilatation. Labor guide is started when cervix is 5 centimeter or more dilated. So now we will follow the evidence-based timeline. Patient can be 5 centimeters dilated till less than 6 hours. If it is 6 hours or more, it's going to be an alert. So this column is an alert. And we will be plotting it with X. Labor is progressing well. We are going to do vaginal examination every 4 hourly. Descent of the head is by abdominal examination. So we will plot it with 0. This is abdominal examination. Please remember, everyone, it is not vaginal examination. So we have to see the fifth of the head palpable. So as the labor is progressing, we will be seeing that there will be more descent of the head, and we are going to plot it with 0. So here it is 4 by 5th palpable, here it is 3 by 5th, and here it is 2 by 5th palpable.
This column, there is no alert, isn't it, Dr. Shabana?
Yes, there is no alert in this column. Because whenever we are doing this abdominal, this examination, vaginal examination, we are doing the abdominal examination as well. There is no alert. No. Because see, this column is already empty here. So no alert. Okay. Then medication. So we have to be very specific about medication, write the full name. Suppose we are giving oxytocin to the patient, then we have to write the unit per liter and drops per minute. Any other medication like injection pethidine, we have to mention the name, dose, strength, IV fluids, the name and the drops per minute. So here, if patient is not receiving any medication, we will write N, and we have to fill this column every hour. Then comes section 7. This is a new section, shared decision making. So here we will be doing the assessment. So whether patient needs pain relief and how is the progress of the labor. So then we have to write down our plan. If she needs pain relief, yes, we have to inform anesthetist to provide the pain relief. And if she needs companion, we will inform our midwife to provide the companion. And if labor is progressing well, then we can write our plan as continuation of routine monitoring. Okay, and in the end, we are going to write our initials. So if my name is Shabana Ansari, I will write SA. If it was Dr. Kazi Mahmouda, she will write KM. Okay, so this is how we will fill all the sections. Now, we have this new section. This is the second, wait, 1 minute. Second stage of labor. So this is again the new section. So here, we will, whenever the patient is pushing, we will mention it by P. Okay, so this is the new section in this labor care guide. Now, few questions which the junior asked in the exam, like he asked about deceleration, kaput, and your molding, the difference between the new and previous partogram. Okay, so here we know the new sections. Supportive care, section 1, section 2, right? Shared decision making, section 7. Separate second stage monitoring, and there is an alert column. How to do the monitoring, for how long? Monitoring of first stage of labor is until 12 hours only. This is very clearly mentioned in the labor care guide. If I will go back here, you can see this is the active first stage of labor, and this is still 12 hours only. This in the primigravida. In the multigravida, like it is up to 10 hours. So this also we have to remember that first stage of labor is till 12 hours. In the multi till 10 hours. What is the difference? So just remember the difference. So we are starting the labor care guide when cervical dilatation is 5 centimeter or more. Now there is evidence-based time limits at each centimeter of cervical dilatation. We are not using the fixed 1 centimeter per hour alert line and action line. We have a second stage labor monitoring and supportive care, that is the recording of the labor companionship, pain relief, oral fluid intake, and posture. Regarding the uterine contraction, we are measuring only the duration and frequency. There is no strength now, only duration and frequency. And another one is, this is the alert column. So any deviation from the normal has to be highlighted, and then it has to be managed accordingly. Okay. Decelerations, we know because we are we have been reading the CTG, and commenting on the CTG like anything. So yes, the deceleration, just keep it very simple in the exam because you have to say everything within 10 minutes. So it is transient decrease in fetal heart rate by 15 minutes for 10 seconds, and there are 3 types. So you can ask your junior, do you have any idea about the types of deceleration, early, variable, and late? Okay, yes. Early, this one is just like the mirror image. It starts and ends with the contraction. Variable, it doesn't correspond with the contraction. It can come before, with, or after the contraction. And mostly it occurs because of cord compression. Management is changing maternal position. Early deceleration, we know it is because of the head compression. Late, this starts after contraction. Dip is after the peak of contraction. It doesn't come back to normal baseline even after the contraction passes off. This is the very concerning one, and it suggests fetal hypoxia and it needs intervention. Okay, then what was the other question? Caput. So yes, it is the swelling of the newborn scalp. There is buildup of serosanguinous fluids below the scalp, and it occurs because of pressure on the baby's head as it passes through the birth canal during prolonged and difficult vaginal delivery. And most of the time, it resolves spontaneously within few hours or days. What about the degrees of caput? 0, no caput, +1 is small, +2 is medium, +3 is large. So +3 is an alert. So this one has to be mentioned in the labor care guide. Likewise, molding, this is the overlapping of fetal skull bones as the fetal head passes down the birth canal. Degrees of molding, 0 is no molding, 1 plus sutures are opposed, 2 plus sutures are overlapping but reducible, 3 plus sutures are overlapping and not reducible, 3 plus is an alert. It has to be mentioned in the labor care guide. And then closing the station, we know you have to ask for the feedback as well. So how was the session? How did it go? I hope now you are able to fill all the sections of labor care guide. Any questions? So offer her articles and videos on labor care guide and tell her if you wish I can arrange another session on labor care guide. Thank you. Have a nice day. Don't forget to involve your colleagues, midwife, anesthetist, consultant, even in teaching stations. So this is not just about communication with your junior colleague. This is communication with other colleagues as well. Got it? Fine. Any questions? Someone wanted the previous slide? Someone wrote something in the chat box. I will share the recording. No worries, my dears. Don't worry. All right, so I hope now it's clear, the labor care guide.
Ma'am,
Yes,
I'm
ma'am.
confused with section 5.
One moment. I'll go to section 5. And I will want someone from you people to answer. Yes.
Yes, ma'am. Actually, in our country, this labor care guide is not using. So I'm confused. That is, you said when the cervical os is 5 centimeter. So is it a lot when the os is remain at 5 centimeter for 6 hours, or is it a lot when the os need to wait less than 6 hours, more than 6 hours to become full?
What do you see here? 6 hours or more is an alert. So less than
Yes.
6 hours is okay. But 6 hours or more than 6 hours, if the patient is 5 centimeter dilated, it's going to be an alert.
So after 6 hours, if the os is still 5 centimeter, it is a lot.
Yes. It is alert.
But ma'am, we are doing PV 4 hourly, and then even after 4 hours, if she's 5 centimeter, any which way we'll be taking an intervention because there is no 1 centimeter for the dilatation increase, no ma'am?
Yes.
Is it delivery time, doctor?
See, if labor is progressing well, we will be normally doing vaginal examination every 4 hours, right?
Yes, ma'am. And that should be 2 centimeters within 4 hours should be the normal dilatation.
Normally it is like that. Yes.
Yeah.
Okay.
So,
ma'am, are they saying that from 5 centimeters till 10 centimeters, if it is more than 6 hours, that is what is alert?
Again,
I mean from 5 centimeter till full dilatation. If
yes.
that increases more than 6 hours, that is becoming the alert.
If she is 5 centimeters dilated, she can remain 5 centimeters till less than 6 hours.
But ma'am, even after 4 hours, she's 5 centimeters. We will be doing intervention, no, according to the NICE guidelines. We will either do amniotomy or we will wait for another 2 hours. And if she's still, then we will suspect delay.
Yes, then because see, we cannot wait for more than 6 hours if patient is 5 centimeters dilated. So normally we will be doing the vaginal examination after 4 hours. If still she is 5 centimeters dilated, we can wait for another 2 hours at least, right?
Yeah,
Because
yes,
this
ma'am.
is the time period for her. We can wait till here. Again, after that, she's still 5 centimeters, then we have to do some interventions.
Yes, ma'am.
Right, because what is the aim is that it reduces unnecessary interventions, that we are not going to do amniotomy very fast, right, not starting oxytocin very fast. So it has to be like give the patient some time, because the labor characteristics is different for every woman. Some will take time, some take more time, some take less time to go into full dilatation. And any, okay, one more question was about the second stage of labor. Yes, Dr. Taskeen, what's your question?
Ma'am, actually, one of the questions asked was like, what is the role of introducing second stage in the labor care guide? So what I got in my mind, it is most probably to reduce some unnecessary early interventions which we do in the second stage.
Yes, yes, yes. Because again, we have to see the time here. With the epidural, we know it's 3 hours. We can wait for the primary, for the for the multi, we can wait for another 2 hours. So it avoids unnecessary interventions.
Okay, yes, ma'am. And another thing, like, is it always a document or a paper, or is some electronic, like we can monitor it on a screen in the labor rooms?
Usually, I think it is the paper which we use to fill the partogram, same like that.
Okay.
Any more questions?
And ma'am, if we use this in the first stage and it has been 12 hours, we have to start a new paper.
Yes.
And
yes.
So
if patient is in the first stage of labor till 12 hours, then we have to start a new labor care guide.
And a new labor care guide. If in the first the old paper it was ended with 8 centimeter, then we have to start with 8 centimeter in this paper, new paper.
Exactly. Yes. Yes, yes.
And so the active first stage was over 12 hours. It is abnormal.
It will be an alert for the primary gravida. Because first stage of labor in primary gravida should last for 12 hours. In multi, up to 10 hours. So it's going to be an alert.
Okay, need
Right.
some intervention.
Then, yes, you will be informing your senior midwife, your consultant, and then there has to be a plan. Suppose there is no fetal distress, there is no decelerations, and then we can continue for a few hours. And if intervention is needed, then we have to intervene. Because if there is delay in the first stage of labor, then what's going to be the management? We have to expedite the labor, isn't it?
Yes.
Yeah, it can be by amniotomy, it can be by starting oxytocin, isn't it?
Yes.
Yeah.
Yes, yes, ma'am. Thank you.
Okay. Any more question? I hope all the sections are clear for everyone. And decelerations, caput molding, just remember because like these were the questions asked in the exam. Okay. All right. So thank you everyone for your participation, and it was a good interactive session. Okay.
Thank you, ma'am.
So much,
Thank you,
ma'am.
Thank you,
doctor.
ma'am.
Thank you. Okay.
Thank you so much, ma'am.
Okay, my dears. Bye-bye. Good night.
Doctor,
Yes?
Thank you, ma'am.
labor ward prioritization recording will be available.
Oh
missed.
my goodness, that was done by Dr. Ahmed. So you people didn't ask
I
him
missed.
to record. Okay. So I think he was not able to record, you know. So no, the next time, just be particular if you can just ask to record. Sometime what happens that whenever we are recording a session and we write in the group that session will be recorded and shared, there are very less participants, you know. But what I have seen that when you are in a live session, that is more interactive. But yes, at the same time, you people are busy. So, okay, we will try it. I will be sharing this recording in a while. Okay.
Okay.
Yeah,
Oh,
ma'am, another request.
yes, please.
Yeah, ma'am, regarding this timing of the primary and the multi, I have confession, because what I can see in the Green Top guideline, it was published in 2020. Though the Green Top, yeah, we know that is like evidence is more in terms of like more important, but in the NICE guideline, it was 2023. So my request is, if you can manage time, just see and tell us that what should we follow, because in the labor care guide also it was like as like the GTG 3 hours and 2 hours, but this NICE guideline is creating confusion on me. That extra 1 hour can be
Yes.
until for the Nalipera. So if you can check that and confirm for us, ma'am. Thank you.
Right. Okay. Okay.